Basically, the problem is that the law supposedly says, or well, it does say, that subsidies for health insurance on the exchanges should be given to those who buy health insurance through state-run exchanges. But then there's the problem of people getting subsidies to buy health insurance through states that have not set up exchanges, so they're buying it from the federal exchange. And so the real question is that even allowed? And you go back and forth with your legal interpretations of as established by the state. And in case you're wondering, fun fact, it appears 9 times, that phrase, in the Affordable Care Act.
That's correct.
We'd like to confirm that Peter Dudziak has in fact read the entire Affordable Care Act, so that's quite impressive.
Take that, Congress.
I was off the cuff. I had no prior knowledge. Dr. Jeff, would you like to comment on Kimber's rule?
I mean, it's a curious case, I think, in some ways, because it seems like they'd be able to look at some of the lead up to it, the preparatory meetings, the understandings, as well as the implementation afterwards, like through the IRS and other organizations. And it seemed like the understanding was that even despite those 6 words, that the subsidy should apply to those going through the federal government exchange. But that would be 34 states, I believe, that would be affected by it. So it would be a major undoing, major chaos, because these people who are getting the subsidies would then have a very difficult time affording their health care. Sorry about being far away from that.
Thank you, Dr. Jeff. So at this time, I know I asked you a little earlier about any questions you might have, and so that's going to be kind of the bulk of our night. It's audience questions, so any questions out there in the audience, we'll get you Nash right behind you.
Hello. On the point of the Cambridge rollout, I think it'd be, I want to make a point of clarification that a lot of the reason why many of these states that don't have their own state coverage is because their state governments refuse to implement the state system because they did not want Obamacare for their states. That doesn't mean, of course, that their citizens don't want to purchase healthcare if they do. So it seems interesting to me, and I'd like to hear your thoughts on. It seems to be sort of an intentionally constructed problem in that the places that don't seem to want it aren't implementing it to the letter of the law, so that it will be taken away.
I mean, there is kind of a deep irony in there that many of these states also have high need exactly for this care, and they have lots of citizens that are getting some of the highest allowable subsidy amounts, so they would be tremendously affected by this ruling.
Any other audience questions? Can you explain?
Mine isn't actually a question, it's more of a comment.
Mary Beth, can you introduce yourself for the crowd? Just
my name is Mary Beth McCarthy, and I'm actually the niece of Senator Eugene McCarthy, who always felt that until this country had a national health care program, that we were never going to be able to solve a lot of the issues. But I, for one, not because of him, but somebody who believes in a single payer plan. There should, in this country in which we live, there's no reason why somebody who needs any kind of health care isn't available to them. But be that as it may, we're not there. We are here. And I think in terms of the philosophy of it, as we are looking at a plan, that it is, and because St. John's and St. Ben's are really institutions that teach how to live as a community, to be community builders, and to be in service to, that I feel it's really important to, as a member of the society in which we live, that we are a community where the young look after the old, where the rich have a responsibility to pay attention to the poor, and that those of us who are healthy have a part of the network of the community that take care of those who are sick. And if this is an insurance plan, the plan is not really to protect ourselves against what might happen, although that isn't part of it. But we are paying into a system and a community that if we don't benefit from, somebody else does. And so that's really my comment, and I'd love, for each of you to, comment on that.
Thank you very much. I guess we can go down the line here. Panel members kind of reflect and respond to the comments. Peter?
Okay. Well, you covered a lot of topics. So you talked about single-payer healthcare. I think single-payer healthcare, personally, I think that'd be very, very difficult to implement in a country of this size. And I think that was the point of why the Affordable Care Act was made to be the way it was, to sort of combine aspects of the free market private health insurance and like more state-run, it's supposed to be like sort of a combination, middle of the ground kind of thing. I think that was the intention. So I don't really know much about single payer and how that would really work in the United States.
Yeah, we got it. I get it in 15 years from now. CMS, Medicare is essentially a single payer system with private doctors. And so it'd be interesting having a panel in terms of, what, if you're a senior citizen, what do old people get out of it? And it's interesting to look at groups that represent old people, which now include me since I turned 50 this year and got my ARP card. But, groups like the Association of Retired People, persons, whatever it is, just gives me discounts at the Motel 6, so that's all I need. When you look at that, they represent people, essentially 50 and above, so they've got kind of a split group there. For those of us in between 50 and 65, particularly people who may have lost their jobs in the economic downturn, something like the Affordable Care Act. And I hear you, something better than the Affordable Care Act could be, extremely valuable and stress reducing. So we have a multiplicity of systems in America. This book was written right before the Affordable Care Act, so 2009, and kind of the lead up to it. But what it basically does is look around at other parts of the world and kind of this American way of doing healthcare. We've got a few misconceptions. Number one, that it's the best, and number two, that we couldn't do anything like a single-payer system, because we do. So we've got different systems from the Indian Health Services to the VA to Medicare. We've got a lot of experimentation out there, it could. I think it can be done technically and all that. Politically, it can be a real challenge, because in some ways, the Affordable Care Act it's not really a hard-hitting, full-fledged healthcare reform as much as it is an insurance reform to expand coverage and give people more choice. But when I go in, my daughter had surgery this year, the same tests can be ordered, the same payment systems, there's some reform to Medicare, but basically the insurance has changed, but the way doctors practice medicine is changing on the edge, but we're still in a fee-for-service system. So.
Thank you, Jeff. Continue along with any other audience questions or even follow-ups to this. I mean, it's a very interesting topic to consider. I mean, is our idea here, or I guess the idea that was pledged in 2010, is that the correct idea, or maybe we have it entirely wrong?
Mike, so I wanted to ask, you mentioned this is kind of a middle-of-the-road policy. So that naturally leads me to question, why has this become so divisive? And should it have been changed to be either less divisive or to be more focused on a single payer system? Because that seems to be a little more of an extreme answer to the question. And I'm calling everyone's input on that.
Sir?
As for one, partisanship. That's why it's a big issue. They don't like it. They like some parts of it, but not all. It really comes down to, oh, we like this, well, God forbid we have that. They're picky in Congress.
Who's they, Peter? Who would you define as they?
Congress.
All right. Anne, you want to go ahead and jump in?
I guess I would just echo what Peter said. We're the people in Congress right now aren't always going to agree on everything or nothing, as it seems sometimes. And it was going to be a divisive issue anyway, and that if you some of the people we have in Congress right now just perpetuated that issue, that it divided us along party lines that wasn't replicable. Wasn't gonna happen.
A couple years ago, they came out with a study from an expert panel that showed the amount of waste in healthcare delivery each year. Being in peace studies, we always used to look at the Pentagon budget, and we were appalled, you know, when it was $270 billion, and then with wars and, you know, the regular budget would creep up about $500 billion, and then, you know, plus the cost of wars and that. They estimate in waste alone, I believe this is 2012 data, $750 billion in healthcare waste. Okay. So that's one reason why you should be concerned, but waste doesn't mean that people aren't being paid in that. There's a whole bunch of different kind of definitions of waste. MRIs perhaps that wouldn't be needed to actually treat that condition. Tests that were reordered because of a lack of electronic medical records. People who were discharged into social environments where they're going to fail and enter the emergency room 2-3 weeks later for very expensive treatments again. So we're trying to deal with some of that within like the Medicare, Medicaid system with payments. But my understanding, if you're getting health insurance, you know, getting your subsidy off the exchange or have employee-sponsored health care, like I do, that, you know, the insurance companies are then still paying doctors largely on a fee-for-service basis. So there's still the incentive, you could say, to overtreat, and the disincentive a bit on my part to care about it a whole lot. One of the big changes has been is deductibles have been creeping up, and that's an interesting thing that gets hard to separate out from the Affordable Care Act, because that's not mandated, but just as I was walking over here, our benefit newsletter came out to inform us of changes that we'll have in our health plan this year. And it's basically things that put more of my skin in the game. So I have concern about that. But once I get to a big bill, then I don't really care, because then it's the insurance thing.
Thank you very much. Hope that answered your question in any way. Diana?
Yeah, so I think everyone has expressed at some point that there are people who are uninsured and people who were uninsured. And I'm just wondering if each of the three of you had a comment on perhaps what, you know, people who are uninsured before, like, is that a certain group of people who are more prone to that, or maybe who don't get their jobs, or maybe they're who, like us, are choosing not to get health insurance? And then what have you guys seen in terms of states enacting programs? I know Minnesota had a series of TV ads, so I don't know if you know if that's pretty typical for the states who do have their own programs, and then on a national level, what that looks like. In terms of trying to encourage people who are uninsured to sign up for these programs.
Start this question by turning over to John here. John, you can introduce yourself, give your background here.
I'm John Schlein. I actually entered that summer with the Washington DC's military program. Great program for those who are interested in doing a summer in Washington DC and I'm interested. And I actually entered with Ascension Health, which is a Catholic nonprofit healthcare trade association. And what they do is they look at policies, or advocate for policies that benefit their hospitals. They operate Catholic systems for the United States. Ministry of Health Systems in Wisconsin, for example, Genesis in Michigan, etc. One of the issues, if you kind of address that question, one of the issues that I spent most of my time with this summer was Medicaid expansion. And that's one of the key provisions under the Affordable Care Act which means that states would expand their Medicaid systems to 138% of the federal poverty level. I don't have the exact numbers of what that would look like. And the biggest issue, I think, it's like the YouTube video, I think it's all in terms of how you phrase that, the term or the idea. Most governors, especially Republican governors, will see Medicaid expansion under the ACA, and they will disagree with it completely. So one of the biggest challenges is to be able to code that in a way that's more agreeable to Republican governors. For example, maybe opportunity or something along those lines, using terminology that they agree with. One interesting case that I saw during my summer was Governor Rich of Michigan. He's actually a Republican governor, but he's actually one of the governors that did go forward with expanding Medicaid. Despite his political ideology, on the basis that it was just the right thing to do for the people of Michigan, whether or not that's inspired by the desire to run for the election or the voters, and political scientists can decide that. But that's one interesting case that I looked at this summer. And increasing access to for the more vulnerable.
Very insightful response, John, and it's a great experience that John had this past summer in DC and was able to elaborate on that. I don't know if the panelists would like to add any comments on that.
Just kind of explaining why some are fearful as well is that the federal money for the expansion kind of goes down over time. So then some people have opposition, like unfunded mandates or whatever, see this as like an unfunded mandate in the future, I guess. So some might see it as not a good deal to take, despite perhaps being the right thing to do.
I was wondering if Diana can actually repeat the question.
Mostly just what's the difference between states and trying to get people involved sooner? It doesn't matter basically. Are there more people, like for example, I know Minnesota had a teen ag campaign trying to encourage young people to sign up. So who's being targeted and is it working in the states that have non exchange?
Well, I would say that young people are definitely being targeted, especially in Minnesota, because as we were saying at the beginning, that young people are the biggest group to be uninsured oftentimes, because once we graduate college and get off of our parents' health insurance, our first priority isn't always to get our coverage or our own insurance. It'd be that because we are taking entry-level jobs that don't offer health insurance from our employers, or because we don't think we need it, because we think we're invincible, that we're not going to, like Jeff said earlier, we're not going to go to the doctor and get preventative care, that we're more likely to go to the doctor after we tear our ACL and have this gigantic bill to pay. And the healthcare law is aiming to reverse that, encourage young people to get preventative medicine so we don't have to pay those large bills down the road. I don't know much about national versus state besides Venture. Obviously only been exposed to that, but I don't want to think more about that.
As for states on who they're being enrolled, Anne's absolutely right. They want the young people, the young and the healthy. They're generally pretty healthy, so they're going to take less out and put more in, save it for the people who are high risk to them when they are older and need health care. Sort of like a rolling thing. But as for states, I don't think there's really that much of a difference. They're all trying their hardest to get young people. You asked about ways they do it. Oregon had Spotify ads. Lord knows why I was getting ads for the Oregon State Exchange.
I guess ads and I guess people, systems, especially I know first, system health, we had, I don't know the exact phrase or terminology, but it had the correspondence, also people, offices that would help people sign up for these exchanges during the times where the exchanges were open. So there's actually people who help explain this stuff and encourage people to sign up for exchanges and walk them through the process, because even though it is a daunting process to sign up for these, to get these exchanges.
Thank you very much, panelists and John. At this point, I kind of want to, this will be a high audience participation question, hopefully, but I just want to focus on the idea of healthcare in and of itself. Rather, is this audience panel a universal human right in the U.S.? I mean, if you want to, that's kind of a big term to throw around, but I'm just kind of curious what some of the audience members or even panel may think about that. It's a hot button issue, to say the least, but I'm interested to hear some opinions.
I'll let you go first, actually. I'm Steve. Oh. Okay, so thank you. We talked a lot about this in our medical ethics class, and I think if you asked an individual in America, they would say, "Oh, of course, healthcare is a human right," because you see that people get emergency medical care. They will treat you no matter what. But the fact of the matter is that's not the reality. And if you look at other countries, it is true. In Europe, there's France. In Germany, Japan, basically, you have everyone covered. And in America, you do not. And it seems sort of strange. And as was mentioned earlier, a single-payer system typically lowers the cost of medicine, whereas this Affordable Care Act, I don't believe, correct me if I'm wrong, but there's not any stipulation really that handles specifically the primarily cost of medicine within America, which I feel is like the most pressing matter, because if it's not sustainable economically, it will be unsustainable overall and will not result in long-term changes. Sort of like you said, Dr. Anderson, the unbending mandates, it's just not possible, in my opinion.
Any of the panel or audience members who would like to respond to that? Tyler, can you add in here?
I had a response. I had a different question.
Oh, yes, a different question.
Yeah, I just want to say that concerning like ER care, I think that is a common kind of misunderstanding. That's where statistics can kind of help, you know. It's hard to prove that people are racist in certain, you know, that's because you're a racist kind of thing. But statistics, you know, if a certain percentage of people are stopped for jaywalking and they happen to be black instead of white, you can kind of go, maybe something's going on here. And so in a similar way, when you look at you know, essentially what are preventable medical deaths, then you have to ask, you know, why. And some of that is a lack of access to regular medical care that the crisis situation ER can't solve, but having health insurance, having regular treatment might be able to keep you alive. So that's why the U.S. does so poorly. And the UN overall rating of the healthcare systems, the U.S., you can watch kind of a fun little YouTube thing. According to the World Health Organization, we finished 37th. So if you think that's good, all right, 37. You know, we can all eat pizza and go home, but otherwise, let's
I wanted to revisit your question a little bit, because we look at the systems, particularly in Germany, but also in France and many other single-payer systems in Central and Western Europe. They all kind of on top of one central system, which was created in the late 1800s by Otto von Bismarck, the leader of Germany at the time, the chancellor. And it was largely due to the fact that there was a strong socialist movement that was collectivizing factory workers in these countries. And so with the collectivization of factory workers, they were pooling their resources to buy health insurance. And that was one of their major objectives, because the conditions in factories were so deplorable that they needed money to get help. And as a means to take the wind out of the sails of these factory workers, this instilled the Bismarckian system. And we never had that in the United States. We had some limited leftist movements, we had some very limited workers' rights movements, but we were much more effective at putting them down. So when we look at places like, particularly Europe, look at Austria, Germany, France, the Nordic states, they believe it's a right out of almost like necessity because their political necessity for it was there. Whereas in the United States, we keep acting like healthcare is a commodity because we had a very disparate movement when it came to actually enforcing the demands of the people for better health. And so that sort of comes to why the prices keep going up because we don't necessarily look at it. We never had a cultural moment where we would say we're going to do something about health because it's dangerous to not.
It's a very interesting perspective, Kirby.
But does it have to be necessarily a cultural thing? Because some of these, it doesn't have to be that political view, or could it be an economic view? Because I believe Clinton tried to pass health care that was based solely on economics, and it was failed. However, economically, these other systems seem cheaper. We're paying a premium for our commodification, so I just find that to be very bizarre that we're doing that in a country that's so. A part of our South is to be economical about everything. We're not doing so in this respect.
Anybody need
Well, I was just going to say, Dr. Phil would say, you must be getting something out of it. And so somebody must be getting something out of it. The health industrial complex, Eisenhower warned us about the military industrial complex in his farewell speech and all, but the health industrial complex is a real beast and has some powerful people, and obviously, you talk about ethanol in farm states, and that's tricky, and you talk about medical devices. I know that's on our list for a little bit, and a powerful medical device state like this, and it becomes interesting. I looked a little bit at some of the stock prices of even ones that I see sued quite often, like Stryker, which is knee and hip manufacturer. I looked at from the beginning of the Affordable Care Act, because it was all doom and gloom on what was going to happen to these medical device companies with the medical device tax. Stryker's gone from about 51 a share to 91. Boston Scientific from $6.68 to about 17 today. Medtronic from $42 to 76. Despite many of these have had rollout problems and lawsuits and issues. And the Mayo Clinic last year, a nonprofit, but had a profit of $612 million, which is a record profit, and 6.5%. So it used to be the big bad insurance companies that people used to worry about, because that's the fixes that the ACA has addressed. Insurance companies I would wake up and think, oh my God, did I put our newborn on the policy? Because if I didn't, she's uninsured and we're financially ruined, Or I would think, when I was filling out those forms, that was that mole an abnormal nevi? If I coded it wrong, are they going to strip me from future services? And they had armies of people who were geared to do just that. So now that's kind of gone. But still, what's left in place is a quite expensive medical system. There's just one little correction. I wouldn't characterize either France or Germany as a single payer system. Single payer, when we're talking that way, like the Canadian model, you would have it's like our Medicare services, where you have a single payer who pays private doctors for their services. Then you have things like the National Health System in Britain, where you're actually an employee of the National Health Service. That's different. But France and Germany both rely on models that aren't all that different from ours, except in one key point. And again, we're the home of United Health and Bill McGuire, and that generally they rely on not-for-profit insurance companies. So the profit motive and the discipline of Wall Street might, in a way, end up, costing us.
Any other questions out there? Oh.
I no longer complaining with the politics of Pint event, so I can actually show my opinion a little bit. Some of you might not be surprised to know that I do not care much for the Affordable Care Act, but yeah, no, really, Kirby. I just think it's important to also understand people who are who might disagree with Kirby's analysis of, or these two analysis of what whether or not this is actually a free market system that we're currently in. We currently were in before the actual Affordable Care Act was passed. You know, we have an elaborate system in which we're incentivizing employers to then provide provide tax incentives for them to then provide insurance for their employees. We had a very indirect system of actually purchasing health products or health things. So I mean, it was kind of a murky market in a lot of ways. I think personally, I think a lot of people on the right might think that, you know, that is actually what was pushing the price. The fact that it wasn't a free market enough. So I feel like, you know, there's another extreme to this, in which you have a very free market system. Maybe you subsidize care for people who are maybe in poverty and less able to pay. So I just wanted to present that alternative scenario. Also, in terms of medical device companies, I think conservatives, people on the right might say that, you know, the very concept of taxing companies that are the companies that are actually innovating and developing these medical innovations is a little bit flawed, because you're going to use those profits that you make out of those companies to then pour that into R&D and come up with new and great innovative products. So more from a philosophical standpoint, a lot of people on the right have a problem with that. I just wanted to present that point of view.
Appreciate that, Tyler. It's good to get both sides of the argument. Continue.
Alright, first I'm just going to go off of what Tyler said. It's a complete myth that the U.S. has a free market healthcare system. What we have is a hybrid. And that's part of the reason it costs so much, is because we have this awkward interaction between the free market and the government, and they have to work together and work in opposition, and it leads to a lot of extra, what some people would call plunges, that make it cost a lot more than it does what it is. That's one of the big reasons it is. So one of the best ways to deal with that would be either to have a single payer or a free market system like Canada is. I would say that for a country like us that's so diverse, the country of France is the size of Germany. And so if you want a better system, I think, and especially in a federal society like ours with 50 states, it would be much better to have more of a free market system than we do, where the states have more power in deciding how they run their health care, and that would lead better outcomes and better outcomes.
Any of the panelists like to comment on the recent opinions we've heard?
Well, I mean, it's interesting. People want different things in their healthcare. For some people, medical devices are important. It's hard to, you know, when my mom needs something like that or something, I'm happy that that stent is there. Or if I've had 2 knee surgeries, maybe I'll be a candidate for the Stryker knee. I hope that I'll still be able to sue them big time when it doesn't work, but we'll see. There's some craziness there where stockholders at Medtronic can sue the company for essentially keeping some of the information about some of the problems that they were having with their infused product. The stockholders can sue, but the actual people who had it put in their bodies and are suffering from the pain or from the cancer or whatnot are shielded by an FDA law. So it's tricky, but there are sort of measures of these things, of healthcare investments, quality and dolly, and so we can talk about how we spend our healthcare dollars. And generally, some of those medical devices, those heart ones that look pretty cool for stenting and whatnot, have an extremely high cost for what we either call disability-adjusted life years gained. If you wanted to put your money in the way that gave you the best health years, it would be in covering more people with smoking cessation programs, covering those that are likely to be undercovered on depression medication. On those, you end up, if you get a depressed mother, you also improve the lives of those around her as well. So we spend an enormous amount on devices. And this is clearly not a partisan thing when we talk about Republicans, because the senators that I was referring to were Franken and Klobuchar on being strong defenders on that, just because it's an important industry in Minnesota. But again, to get to some of the statistics, we want to look to see if we're putting our money in the putting our money in the best places or not.
Thank you, Dr. Duff. I realize you got Kirby here.
I'm not going to lie. I just want to respond to Ryan's point on the argument that America's too big to have an effective universal health care program. I mean, yes, size-wise we are much larger than France, the population is much larger than say Germany, single-million people. But we also have the largest economy in the world. We have the most productive workforce in the world. We have more than enough capital to cover the needs of the entire population if we use it in an effective way. I mean, Canada is a huge country as well, but they have a relatively effective medical care system. I mean, it doesn't work 100% all the time. As in the United States, we have an opportunity that is way different than saying, oh, we have too many people in the United States that are too big to actually have an effective system. And you mentioned the federal system as well. Even under the federal system, that breaks down all of these different states into areas where we can have this. Like Minnesota is a reproductive state. We can have an effective state single-payer healthcare system, and then have states like Alabama or Mississippi that have poor productivity and low income be covered by a federal system. And we have, again, the idea that we can't have universal healthcare because of our size, because of the number of people is negated by the fact that we have this unique system that is very productive and has much content.
Thank you, Kirby. Any other questions? Yeah.
I was just going to say, I mean, we do just have so many systems. So if we ever talk about the American system, or if I say that, just slap me, because there's so many. But I mean, Medicare is largely a federal system, but Medicaid's a joint system, between the federal government and the states and that. So each state can kind of put their own little stamp on it and experiment. So I believe too that there's ways to do it.
Dr. Lister,
real quickly, good discussion. So, my understanding of healthcare spending in the country is around 18.5%, 19% of our GDP. For the entire country, 19% is healthcare spending. And that's one point that Democrats, Republicans, Libertarians, everyone agrees that it's way too high, because the second highest country in terms of percentage of GDP spent on healthcare is right around 8 or 9%. So clearly like half. And then it's 7, 6 is right on down. My question though is, my understanding is that the bulk of healthcare spending is in the last few years of your life. In other words, and this is safe to say in a room full of folks under 23, 22, 5, whatever, but the bulk of our healthcare spending is in the last 3, 4, 5 years of your life. So my question is, getting back to perhaps Governor Palin's death panels and rationing and so forth, what do you guys think of, is it right when 90-year-olds get hip replacements or get open heart surgery when you're 85 or 95 or whatever, pick your age, I don't really, but what is that, and Medicare's paying for part of that. When do we start rationing, or what's right and what's wrong with that? I don't have any answers, I just have a question. What do you guys think of that? Because the bulk of the spending is overwhelming, is the end of life questions. Anyway, that's all I got.
Just real quickly, an interesting kind of thing to look at is now they look at how doctors die, and doctors die less differently than the rest of the population, because they know what medicine has to offer and what it doesn't in those ends. So sometimes the British that have, kind of really strong on end-of-life issues and strong on cost control, but they don't combine those arguments in the same way. So you just did a very un-British thing, to kind of save money at the same time. So, it stylistically may be different there, but doctors die quite differently. And that'd be, my dad died quite differently of pancreatic cancer. We did it on the cheap. You all should kick in and give me some money. But we didn't do it to save you all money. We did it because that was the best way for him to die, and more doctors know that. And it's really an interesting question for those of you who are going to be medical professionals or doctors, is how do you present the information? So some people, believe, right, in, I mean, most people know it's pretty much taken patient autonomy and paternalism kind of a bad thing. But sometimes people need some help at this end-of-life stuff, which occasionally, you know, got mixed up with death panels or that, or people might know a little better. If you just present people with end-of-life options to a family, I come from a family of 10, it could be overwhelming for them to make a decision. So they make the decision to seek further treatment at further expense. But most importantly, dying in not a good way. So one of the issues is how do you kind of potentially, you know, what is it that doctors know that the rest of us sort of don't know? And how could we get to a system that allows people to know more about death? And there are some things out there. That one, I forget what it was called, Let's Have Dinner and Talk About Death. Just simply to know your parents' wishes and those sorts of things. So you're right about the spending bit.
Peter, Ann, would you like to comment perhaps on your views on later healthcare, later life healthcare?
I should also say just real quickly, my dad had macular degeneration in his last year of life. Medicare would have paid $108,000 to have Lucentis, a drug, injected into his eye if he had not died. He had a couple rounds of injections before then, but at almost $4,000 and some dollars an eye, which they would have happily paid that. Almost all of that would have gone to the drug company and the retinal specialist. So we are talking big, big bucks on some of this end-of-life stuff. There's also an interesting economic argument about, you know, you think like you should spend more on young people, but old people, when your time is really short, it should be of more value to you. So for some people, that expense to invest something so they can say their good goodbyes and kind of pull things together might not necessarily be money wasted.
Especially if it's other people's money.
Yeah.
All right, we're getting closer on time here. We like to do this under an hour. So probably looking for maybe one or two last questions here. Any burning questions that have kind of saved up throughout the night? Hope you hear those.
Yeah, hi. This is another Medicaid-related question. So we talked about Medicaid expansion, but what good is that going to do if the reimbursement rate is so low? And if I understand correctly, part of the ACA is that that reimbursement rate is increased. And I just want to question, have the physicians seen benefits of that increased reimbursement rate quite yet? And are they seeing more Medicaid patients because of that?
Peter, answer.
Peter, go ahead.
Honestly, not really sure what the doctors have seen. I'm not a doctor. Did they report that sort of thing?
Yeah. I mean, I believe if you take Medicare, you have to take Medicaid. Now that's with older people. You know, the Medicare rate, there's, you know, complaints about it. Sometimes it's not raised, but they always get paid retroactively, is my understanding, mostly from, not from reading, but from talking to my doctor friends and that. So access is a real problem, but at least you have that stick of other ways for them to get paid. I think where one of the real problems is, and we're not talking about teeth, but dental, getting dentists to accept it, that's really, really hard for poor people to get dental, having to drive extremely long distances to find someone who will take it, kind of having it be almost taken in a way that's more humiliating to know that you drove halfway across the state because you're so stinking poor that there's nobody in here, you know, kind of thing like that. So yes, Medicaid rates are lower. That might be an argument for the single payer thing. I'm at that stage in my life at 50 where I get my mom's bills because I handle her medical stuff, and I get to see what doctors bill and what the government ends up paying for that. And you might say, you know, depending on your view, oh, that's awful. But then I also get to see what I'm insured by Blue Cross Blue Shield, so my daughter had surgery, what they bill, and then the discount that Blue Cross has negotiated. Through this thing, because we didn't have healthcare reform, hospitals have gotten stronger relative to insurance companies. So if their insurance companies aren't quite as strong because the hospitals have bulked up and bought up other hospitals. The health systems are quite strong now. So if you remember the Time magazine from a few years ago called The Bitter Pill, the whole kind of thing, the guy who kind of wrote that then had a big health incident, and he had an aneurysm, and he just got his bill. And he was surprised to see that United Health, the private insurance company, Minnesota-based, was only able to get like a 12% discount off of these really outrageous rates. So, for me personally, it gets really hard to figure out whether Medicaid rates are like so underpaid, because we live in a world where some things are charged so ridiculously. The charge sheets are so ridiculously high.
One last question, we probably got time for, we got 5 minutes here before we're going to wrap up. Or any other comments from the audience?
One other quick funny thing about Jeff, about the author you just mentioned, wrote the cover story of Time magazine, he wrote a book as well about the medical industry. And then he's also just came out with a new book about his personal, he had cancer, I believe, or he's recovering. Aneurysm, that's right, aneurysm. So anyway, as part of researching the book, he went to United Healthcare in Minnetonka, the headquarters, and interviewed the CEO. This was just on Minnesota Public Radio a couple days ago. And at the end of the interview, he presented the CEO with a copy of one of his bills, which said, bill from the hospital, $0, bill to insurance, $0, patient responsibility, $158 on the bill. And he's like, what the hell is this? It's a $0 bill, why am I getting charged 150, whatever it was? And he showed the CEO and he says, explain this bill that I got. CEO had absolutely no idea what the hell that was, how to, he had no idea. It was just, again, the power is kind of on the hospital side when they're kicking out these, $80 bills for Tylenol and et cetera, et cetera.
It's a very interesting anecdote. Alrighty, well.
Thank you, Richie. That's it.
Anyway,
I have a question following up on that. What does the ACA do, if anything, then, to kind of provide more transparency in the hospital business? Because that's a huge problem that Matt was talking about. Like the fact that they're charging $80 for Tylenol, and you can't find the actual prices. So because they're trying to negotiate, right, with the insurance company. So does it do anything regarding that? And should we expect changes there?
Nothing.
Nothing?
Nope. In fact, drug prices just kind of go up. So the whole drug company thing, they don't really do much in the actual act to combat that.
It reminds me a little bit of when Hillary and Bill Clinton were donating things, and I think Bill blamed it on Hillary for donating his underwear and writing it off at like $7 a pair or something like that to Goodwill, taking the tax benefit, because this becomes an issue also in the amount of charitable care that hospitals deliver, because those charge sheets, those crazy rates, are then sometimes what they're able to deduct. So that charitable care, it's hard to determine the exact amount of like true charitable care compared to just kind of funny money that's written off, kind of crazy bills for this care that was delivered that allows them to reduce their taxes.
Well, I'd just like to close by thanking you all for coming. We've had quite the insightful discussion to point out. Diana, we got one more question, excuse me, one more.
I think I can help get into that a little bit. So, at least the impression I've got, and actually, Hannah, one of your roommates might be able to answer this a little better than I would. So the people who, when it comes to like calculating these types of costs, especially from the insurance company's perspective, these costs and the models they use to construct them are actually how they make their money. Their models they use to construct how they make their money, and therefore they are valuable intellectual property and stuff that they don't want just anyone to get their hands on. And so I think that's part of the problem there, is because our system is so complicated, the insurance companies have an incentive to hide how they're going about this, because that's how they make their money, and they don't want just anyone happening yet.
No more comments. All right, well, I'd just like to thank you all for coming out. beautiful panel here. Very insightful, offered great information, and I hope you all have learned a little more about the Affordable Care Act. Today is actually not the birthday, so it has not turned 5 yet, so keep your eyes open for March 23rd. That is the official birthday. Maybe have a slice of cake or something, I don't know. Thank you very much from the McCarthy Center and everyone, college Democrats, college Republicans, especially Dr. Jeff Anderson as well, and we'll see you next time. Thanks for coming out.